speech and language pathologist is what the way she should have started. But it is a 44 minutes of presentation, within which she has given all glossaries possible and of course couple of videos. Now it is our responsibility to elaborate, dilate wherever we want to. And in subsequent presentations and workshops, we hope you to dwell detail on each slide because it's a book that they presented.
Exactly.
Thank you very much for doing it. In fact, that's all. You have videos running now.
Yes, sir.
You want to show it rather than a couple of videos would be nice because we in fact planned for a short MCQs of 5 or 6 level, but I think this is more valid than that. Please carry on.
So again, just a short clip on what actually fees means. So again, before the secretion rating scale also, so these things are seen before we even start giving feeds to the patient. So a part A is the assessment of the swallowing equipment rather than the swallowing maneuver. So we look for palatal elevation, we look for pharyngeal relaxation and then contraction. We look for pooling of secretions and we look for the vocal cords, whether they meet their complete adduction and their complete abduction. When we move forward for this piece thing, we always see that the symmetry of the contraction on either side, how the PFS contracts and how it relaxes.
Hey. Hey. Hey.
Then we look for the secretions, whether they are present in the PFS, in the vallecula, or they are pouring it into the airway. The glottal closure, whether it's complete, whether we have a phonatory gap, all these things to be seen during the part A. Then comes part B. In part B, we actually check for the swallowing ability or the swallowing maneuver. So we give different consistencies of food to the patient.
Take the whole thing.
So the easiest is a puree, semi-solid that we say. So it's the most, the first one to be used. And we usually ask the patient to swallow 2 to 3 times. Even after 2 or 3 times, if there is residue, we consider that as the bolus residue. So you see insignificant traces here and there in the vallecula, that's just staining. Then we give him something like solid. They give a cracker, we give a biscuit. You see some residue, but still that will not be considered as a bolus residue because that was the first swallow. We ask him to have another swallow, and then if it gets cleared, we consider it's not no residue. But if it persists, then it does come in a residue. So you see some of them staining there at the posterior pharyngeal wall and some of them in the vallecula. The last one would be the liquids. The first thing is that, like as I said, there are certain things that you can know that the patient is aspirating, is that if he has a gurgling